Hello friends, welcome again to this session of the GTN. This is a topic of very interesting in nature because as a clinician you find most of the challenges in this topic because you'll find patients after the normal evacuation sometimes after the termination of the pregnancy, sometimes after the uneventful hydatiform mole, and so that's why clinically it is a very interesting topic, and also for the clinicians also it's very challenging one. Coming to the clinical part of the GTN particularly, well, this clinical part of the GTN can be covered with a few S. A topic is simplified when you'll find out some simplification or some simplification of the remembering the things. The symptoms, number 2S is signs, number 3 is your special investigation you'll do to establish the thing. Number 4 is we'll discuss some things, staging and scoring before the treatment protocol. Number 5 is sabotage therapy or salvage therapy. Number 6 is surgery. Number 7 is your surveillance. Number 8 is something we will talk about the survivors. Ladies and gentlemen, so these are the points on which the clinical aspect of the GTN can be discussed. Coming to the symptoms first, what will the symptoms for this category what we have discussed in our previous part? Either the choriocarcinoma, PSTT, ETT, persistent gestational trophoblastic tumor or the invasive mole, all will have the common symptom is abnormal bleeding. Abnormal vaginal bleeding either following the pregnancy termination or the molar pregnancy or the abortion. Sometimes persistent amenorrhea due to high activity of the HCG, then HCG will trigger the corpus luteum or the ovary, and this corpus luteum will go on producing the progesterone, and due to the sustained high level of the progesterone, the patient will have the amenorrhea. Then other symptoms, what will be more marking to us is the continuous sickness of the patient. Sick look of the patient is very much presentable, or very much something when patient will come to you, you will find that patient is sick rather than her presentation or something like that. So a sick look is more important for the symptoms. Then other symptoms may be if there will be metastatic tumors will be there, then there will be symptoms. If there is metastasis to the chest, then cough, dyspnea, hemoptysis sometimes. If there is metastasis to the liver, then epigastric tenderness will be there. And if there is metastasis to the brain, there will be even convulsions will be there, persistent headache will be there. So all the features relating to the metastasis may be found. Sometimes metastasis to the vagina in the form of vaginal nodule, a pinkish cherries color nodule. Patient will come with that I am having some growth in the vagina, or sometimes torrential bleeding from the vagina they will present, and you will find that the bleeding is from the vaginal nodule itself. So those are the symptoms that can be for the patients of the GTN. Then coming to the signs, what we will get from the patient on examination. On examination, on general examination of the patient, we will find the variable degree of the pallor, the blood pressure may be raised sometime, and there will be persistent tachycardia maybe because of the failure, because of the high TSH level, because the alpha component of the TSH mimics to the beta HCG, beta component of the HCG, and thereby high level of the thyrotropins produced, and it gives the features of the thyrotoxicosis in the form of the tachycardia you can find in the general examination. And the chest symptom, on chest examination you may find some positive signs sometimes, and per abdominal examination sometimes the epigastric tenderness you can find, and nothing much. In the lower abdomen maybe the enlarged uterus sometime we may get, and per vaginal examination we may search for the vaginal nodule. If it is there, then that is probably the almost diagnostic for the choriocarcinoma. And on bimanual examination we will find that the uterus is semi-involuted as per the antecedent period of the pregnancy event, and of course there may be an enlarged ovary in the fornices, that the theca lutein cyst to which occurs many times, and if it is there, that can be revealed. These are some of the signs that can be elicited in the Then the special investigations, well, to establish the serum beta HCG is not the answer, because we have diagnosed this case out of the serum beta HCG only, following the hydrated formol in the follow-up and all. But if it occurs after the abortion, sometimes the beta HCG will help. What is the level of the beta HCG? If the beta HCG is very high after maybe 8 weeks of the the abortion event, then we can think of that yes, it's a case of persistent or something abnormal. Then we will go for the other investigations. And if, as I have told, after the pregnancy termination, after the 8 weeks, if there is abnormal bleeding, then we can go for the estimation of the HPL, that is the human placental lactogen. If it is positive, then the diagnosis is obvious for the PSTT or ATT. Sometimes some literature says that we must go for the estimation of the what is called the glycosylated HCG. What is the basis of it? Why we will go for the glycosylated HCG, not the plain HCG? The glycosylated HCG is produced by the implantation site cytotropoblasts. The implantation site cytotrophoblast produces the glycosylated HCG. So that's why if it is present, it reflects that there is activity of the cytotrophoblast, there is division of the cytotrophoblast, and if we will estimate to around the total HCG level, the ratio is high, that reflects that it is an active trophoblastic lesion that is giving rise to this HCG. But this is more of importance in something called the quiescent HCG that we will discuss later on. But in the special investigation, we will go for the estimation of the serum beta HCG if we are not following up the case. Second, ultrasonography is another. So HCG is reserved for the patients which are not in our streamline of the follow-up for the previous molar pregnancy. HCG also are done because we want to estimate what is our starting level of the therapy. What is the starting level of the HCG so that we can make a score out of it. It will be helpful for the scoring. Then ultrasound is another special investigation that we will do. Ultrasound plus Doppler. What is the purpose? We must ask the ultrasonologist, or if we are doing the ultrasound, then we must look for few things. One is the size of the growth, if it is there or not, whether the growth is present inside the uterus or not, if it is present, whether it is invaded to the myometrium or not, and what is the size of the growth. Then what is the volume. We must ask for the volume of the growth and the Doppler nature, size and site, whether in the cavity, whether confined to the cavity, whether embedded to the inside the myometrium, then the Doppler nature. If you are a sonologist, you will be really scared to put the Doppler over this choriocarcinoma or the GTN. There are a lot of vascularity will be there, pumping like anything, and if you put the Doppler and if you put the cursor on it, power Doppler, then the RI will be less than 0.5, and the diagnosis will be obvious that this is a case of a vascular growth inside the endometrial cavity or the inside the myometrium. Other investigations like the blood investigations, blood profile we can go for. Special to mention, we can go for the thyroid profile estimations, as I have told the implications why it is to be done, because of the mimicking of the beta HCG to the TSH component. Then we can go for the investigation. There is a debate on the DNC, not debate. To establish GTN, we should not go for the DNC. If we are following with the molar pregnancy, no need of going for the biopsy, because something to do the biopsy for a suspected case of GTN is very, very dangerous. If you do the biopsy, the patient will bleed like anything and you may lose the patient then and there only. So never go for the biopsy to establish this is a case of GTN if you are following for the molar pregnancy. If you are dealing with a case of abnormal uterine bleeding following abortion or following the normal pregnancy termination, then you can go for the biopsy, but that must be very carefully, because that may bleed many times. So DNC is very reserved, and that is not advocated much to diagnose the choriocarcinoma or the other variants. Then other CT scan, MRI, PET scan are not that indicated unless and until it is very much suggestive from the symptoms or the signs. In that case, we can go for the CT scan of the chest if the chest symptoms are there, the CT scan of the brain if it is there, PET scan if we are suspecting a very metastatic disease, then we can go for. Otherwise, that much not indicated. But something is an X-ray is a routine one. Before going to the CT scan and all, X-ray can be a very screening type of the investigations we can do. And what we are expecting, very typical of the X-ray is the cannonball type of the shadow will be there, a patch like cannonball will be there in the chest X-ray, and that is a very much pathognomonic for this choriocarcinoma or the metastatic variants of the GTN. These are all about the investigations and the supporting investigations for the chemotherapy we have to go for. If not, as we are planning for the chemotherapy, we must do the renal function test, we must do the liver function test, we must do the CBC to have the what is the status of the hematopoietic lineage, and all these things we have to do before going for the chemotherapy. That is a separate thing. Then something on the staging or the scoring. Staging in GTN is not given much of the importance. Staging, as for the criteria, is staging. If it is confined to the uterus, it is stage 1, then confined to the pelvis, stage 2, then metastasis to the lungs is stage 3, and metastasis to the brain and other sites is stage 4. So that is the staging, but the staging doesn't help for the any type of planning of the therapy. That's why next important thing is the what is called as scoring proposed by the WHO, FIGO and all of us, we follow the scoring system before the planning of the therapy for the GTN. There are 8 things are there in the scoring. Altogether 28 points are there. The 8 points are the age of the patient, antecedent pregnancy event, either due to the term pregnancy or after the molar pregnancy, or what is that. Then duration, what is the duration, what is the starting HCG level. Then something regarding the mass, what is the metastasis, where the metastasis has occurred, number of metastasis, and the growth size. What is the growth size, and the prior chemotherapy, whether it was a single chemotherapy or the multi-agent chemotherapy. All these 8 things are taken into account for the scoring system. Accordingly, the scores are given 0, 1, 2 and 4, not 3. And total score is 28. We can find the score chart in our books, in our net, what is there in the mobile. We can immediately go to the score chart and we can find out accordingly, and we can tabulate from the patient's history and investigations, what is the age and all. And total score of less than 7 is something called the low risk. 7 or more is the high risk, and 12 or more is the ultra high risk. Why this is necessary? This is necessary to plan the therapy. What is the therapy? Something called the sabotage therapy or the rescue therapy, you can say, and something called the salvage therapy for the advanced or the metastatic lesions. Or the sabotage therapy, well, the chemotherapy is of choice, and the GTN are very sensitive tumors. The syncytial trophoblasts are very sensitive tumors to chemotherapy, and the chemotherapy is given. Different regimens of the chemotherapy are there. For the low risk group, the single agent chemotherapy is given. Always single is started, and the agent of choice is the methotrexate plus the folinic acid. Methotrexate is given as on the day 1, day 3, day 5, day 7. It is given as IM or IV, 1 milligram per kg body weight. And the folinic acid is given, it comes in the name of the leucovorin, and it is given as IM on the 2nd day, on the 4th day, on the 6th day, and on the 8th day, in alternative days. This constitutes one course of the chemotherapy, and this chemotherapy has to be repeated after 7 days. Suppose it finishes on the 8th day, then after 7 days the second chemotherapy, after 7 days. It's given. So up to how long we will give? Up to till minimum 2 normal level of the HCG we get. Till then we will give the chemotherapy at an interval of, you can say, interval of 2 weeks from the starting of the chemotherapy. From the day 1 it will count, then after 14 days the second course of the chemotherapy is started. If methotrexate is resistant or there is a reaction to the methotrexate, then we can go for some other agent that is called the actinomycin D. Then the high risk group, multi-agent chemotherapy is given, and the choice of chemotherapeutic regimen is Imaco. The Imaco is given, and here the drugs are given on the 1st day and the 2nd day, and this cyclophosphamide and the oncovin is given on the day 8. So the course is completed on again this 1, 2, this one and this one on day 8. For this chemotherapy, the patient has to be hospitalized And for the single agent chemotherapy, the patient need not be hospitalized. She can take at home as per the regimen. But for this chemotherapy, the patient has to be hospitalized because these are very much toxic agents and gives the toxic reactions will be there. That's why the hospitalization is necessary. The second course of the chemotherapy is given after 7 to 14 days of the completion of the chemotherapy. Up to how long we will give? We will give 3 cycles of the chemotherapy after the normal HCG level is achieved. Here, 2 cycles of the therapy. Here, 3 cycles of the additional chemotherapy has to be given after the normal HCG level is achieved. Then something on the ultra high risk when the score is more 12 or more. In those cases, we cannot go for the upfront chemotherapy because the patients are very sick, the tumor volume is more, and if we give chemotherapy, there is a lot of lysis of the cells will be there, and a lot of tumor necrosis factors will be there, and patient cannot handle those volume of the tumor necrosis factors, and ultimately we may lose the patients. That's why first the salvage therapy is given, the low dose chemotherapy is started either with the EP regimen, etoposide and the cisplatin regimen we give, and then low dose is given for 1 or 2 cycles. Then when the patient is stable a bit, then we go for the full-fledged chemotherapy, that is Imaco regimen. If Imaco is not effective, then we can go for the IMA-EP regimen, and even the IMA-EP is not effective, we can go for the carboplatin and the paclitaxel regimens are the alternative regimens. Few of the regimens are there. A lot of things are there that is you can leave for the medical oncologist to deal, and or else we can refer step by step. It doesn't respond, then we can go for the next line of the therapy. The guidelines are there, but all other chemotherapy are of research type. You can apply for if the primary chemotherapy is not of the response type. Then something during the chemotherapy is what we will do. Before giving next cycle of the chemotherapy, we must examine the patient, we must examine for the response, we must examine for anything negative happening, and we must do the blood test. The 3 blood tests are very much necessary. One is CBC, another is LFT, another is renal function test. In the CBC, if the total leukocyte count is less than 3000 or the neutrophil count is less than 1500, if the platelet count is less than 1 lakh, if the LFT and the RFT there is significant rise from the previous level, at least almost 2 or 3 times rise, then we must consider that the next dose of the chemotherapy to be withheld till the normalization of these parameters. That's why before giving the next chemotherapy, we must examine the patient and we must test for this, and we must consider for giving the chemotherapy or not. And during the time of the chemotherapy, there is something is called the remission is there, or plateau is there, or we are happy that response is there or not. Remission, if there are normal HCG level for around 3 or the 4 recording in a span of 3 weeks, then we will tell that there is remission of the PTN occurs. Plateau, if there is fluctuation less than 10%, there is decrease less than 10% occurs in a single cycle also, we will consider that there is plateau is there. Response, if it is more than 10% decrease, then there is a response is there. If there is plateau for 2 cycles and if there is increase more than 10% in single cycle also, then we will call that there is non-response. If you are giving single agent chemotherapy, then we will switch over to the multi-agent chemotherapy. If we are giving multi-agent chemotherapy, then we will change the multi-agent chemotherapy agents, and that is how we will proceed with the chemotherapy. And these are very much toxic chemotherapy agents are there. It must be in a supervised persons and the supervised centers for the benefit of the patient. Then salvage therapy, I have deliberately written salvage therapy. If there is features of the metastasis is there, then we can go for this some salvage therapy. If there is chest lesion is there, it is bleeding, we can go for the excision of the lesion. Sometimes we can go for the intervention to block the particular artery. In the intracranial hemorrhage is there, if the lesion is there inside the brain and intracranial hemorrhage is there, then we can go for the excision. The neurosurgeon can go for the excision, and also the interventional radiologist can also block the particular artery. So those are the things are there. If the story is in the liver also, we can go for the excision of the liver, and also we can block the artery by the interventional radiologist. And surgery for the uterus, particularly hysterectomy, when it is indicated for the patients who cannot go for the tedious cycles of the chemotherapy, follow-up and all, and she has completed a family, more than 35 years completed family, and cannot go for the follow-up therapy, then that is a good candidate for the hysterectomy. We can straight away go for the hysterectomy. If there is a PSTT or the ETT is there, those are also the candidate for the hysterectomy. If there is a hemorrhage out of the perforation is there, then that also qualifies for the hysterectomy. And sometimes during the evacuation, if we will perforate also, those are also the candidate. And invasive mole sometimes doesn't respond to the chemotherapy, then also those are candidate for the hysterectomy if the family is completed. If the family is not completed, invasive mole, we can go for the local excision of the mass, but these are very much vascular mass. We must be very much prepared before the excision, local excision, and we must tie the uterine artery. Sometimes we have to tie the internal iliac artery before proceeding for the excision of the mass. So care must be taken because these are very much vascular mass and bleeds torrentially. Sometimes you will be losing the patient on the table itself. It will not give time even. And surgery, mostly the surgery is done in the open format. Laparoscopy for the choriocarcinoma is not an indication at all because these are very vascular tumor. The uterus is soft. By chance the uterus is punctured, then it will bleed like anything. That's why the advocate is that we must go for the abdominal hysterectomy. We must not even go for the vaginal hysterectomy. If it is a small nodule is there, we may venture for the laparoscopic hysterectomy or the vaginal hysterectomy. But the guideline is that the safest route and the easiest route should be the choice. Then in the surveillance, I have already mentioned in the surveillance, in the follow-up, how to do the follow-up during the time of the chemotherapy by doing the blood test, the local examination and the general examination of the patient, and working on different things like remission, plateau, and the no response. All these things can be made out from the HCG level only, and also we must look for the possible metastasis to the chest, pelvis, vagina, and the brain and other sides. Those are the things during the time of the surveillance. And after the beta HCG is getting normal, as I have told, in the non-metastatic variety, a single course of the chemotherapy is given extra. In metastatic variety, that is choriocarcinoma, in the low risk, 2 cycles, in the high risk, 3 cycles of the additional chemotherapy is given after the normal HCG level. Then the eighth point of discussion is the survivors. What will be the plan for the survivors? Who are the survivors? The 4 beta HCG level is normal in a span of 3 weeks of the time. Then it is leveled as the normal and remission, total remission. After that, however, they are to be followed up very strictly. A monthly follow-up for the 6 months, then 6 monthly for lifelong even. It has been proposed. And at least minimum 2 years follow-up is necessary for these things. Otherwise, there is chance of the relapse or recurrence is there. And next, child wearing is a question, big question. We can allow after the guideline is that after 2 years, but after 1 year also, if you feel you can allow, provided they are the very strict follow-up is necessary. When next time pregnancy occurs, the early ultrasound is necessary to have the possibility of the recurrence or the possibility of the next molar pregnancy. And in the next pregnancy, you must be very careful that there is possibility of the placenta, accreta, increta or procreta is there. That is adherent, possibility of the adherent placenta. That's why in the second trimester you ask the sonologist to look for the placental space, the deciduocarionic space is there or not. That you have to look for in a special care. And of course, after the termination of the pregnancy, there is possibility of the recurrence of the GTN is there. That's why you must be very careful, and we must estimate the beta HCG level after 6 weeks of the termination of the pregnancy. And something that's very interesting is that sometimes during surveillance, one thing I've forgotten is this is in clinical scenario, many times we used to face this problem. Persistent low level of the HCG in the range of 15, 20. We used to give chemotherapy, then beta HCG falls very nicely. And maybe in 15, 20 or 40 ranges, it remains static for even more than 3 weeks, 4 weeks. Even after chemotherapy, it doesn't respond. Even after changing the multi-agent chemotherapy, also the different regimen also, it doesn't used to fall. And those are something called the quiescent HCG. And this is a big headache for the clinicians to define whether it is a quiescent HCG or not, or it is a persistent non-responding type of the tumor. This can be differentiated, as I was telling, the estimate of the glycosylated HCG. This glycosylated HCG is formed by the implantation site cytotrophoblast, and if the implantation site cytotrophoblast are active, there is active division, active lesion is there, then this glycosylated HCG will be formed, and this glycosylated HCG will be positive. Then we can go for the ratio of the glycosylated HCG to the total HCG level, and if it is significant, then definitely we will go for the treatment. We will continue the treatment with the next line of the chemotherapeutic agents. We will not leave the patient. If the glycosylated HCG is negative, then we can keep the patient for the observation even for the lifelong. And the guideline is that whenever it will be active, that can be known by the increased level of the HCG, and whenever it is active, then again we will start the chemotherapy. And some guidelines says that more than 3000 HCG is the starting point of the chemotherapy, because the volume of the group of the cells, active cells, will be there, and that will, the chemotherapy will be active in that point of the time. That is about the quiescent HCG. Then sometimes for this low level of the HCG, another thing is the phantom HCG or the false HCG, and this false HCG is produced by the not produced. This is due to the reaction of the some heterophil antibodies which are which reacts with the antigen, HCG antigen in the HCG assay, and that gives a false positive in the low range. And this can be differentiated by testing for the urinary HCG. If the urinary HCG is negative and the serum HCG is positive, then it suggests that this is a case of the phantom HCG, because the heterophil antibodies cannot be filtered through the glomerulus. So that's why the urine HCG will be negative for this case. Sometimes also due to the presence of the pituitary HCG in the postmenopausal ladies, and due to the LH and FSH secreted in the postmenopausal lady, they also give rise to some cross reaction with the HCG antigen, and gives rise to the false positive result for the HCG. So that way we can differentiate that whether it is an active form or not, and we can continue our therapy or we will drop our therapy. And something for the metastatic variant, that is the cerebral metastasis, we can go for the estimation of the CSF by the lumbar puncture. If the CSF value to the serum value of the HCG, that is CSF to the serum, the serum ratio is more than 1/60, then we will go for the, that suggests that there is metastasis to the brain, and we can go for the chemotherapy for that, and even intrathecal chemotherapy, even radiation to the brain in a high dose radiation is given for the cerebral metastasis or the brain metastasis. So to summarize the things, the clinical aspect of the GTN, well, GTN is happening maybe after the pregnancy event or the abnormal pregnancy event, which can be diagnosed by the HCG level or by the HP study, and the symptoms, there will be abnormal bleeding and other things will be there, or the features like metastasis will be there in the signs, according to the local signs or the metastatic signs will be there. Out of which the vaginal nodule, the pinkish color vaginal nodule is very much pathognomonic, and the X-ray lesion, carnal ball shadow is very much pathognomonic. Lutein cysts are also very much implicated. Special investigations, well, the HCG estimation, we can go for the Doppler study particularly to note the size of the lesion and the Doppler nature of the lesion and the invasiveness of the lesion. All these things we can go for this. CT scanning, we may go for the chest and brain as for the necessity. Something of the DNC which is not an indication, we should not go for. And staging is not the necessity, or the staging is not an implication that we will go for the therapy. Scoring is given importance. There are 8 criteria, 28 the total scoring is 28. Less than 7 is a low risk group of the metastatic variety of the GTN, and more than 7 or equal to 7 is the high risk group. 12 or more is the ultra high risk group. This is designed to formulate the chemotherapy, whether we will go for the single agent chemotherapy or the multi agent chemotherapy. Single agent in the form of methotrexate, folic acid, alternatively 1357 or 2468. And the Imago regimen for the multi-agent chemotherapy 1, 2 and the 8th day, which are repeated on the after 7 days of the completion of the chemotherapy. And before repeating, we must go for the blood profile estimation, blood profile examination, local examination, and the symptomatology and the signs. And the analysis must be given for whether there is remission is there, or plateau is there, or there is resurgence of the disease are there or not. Then surgery is reserved only for the hysterectomy if there is indication which I have told, or the distant metastasis, if it's there, the salvage surgery can be done. Surveillance is very strict. Surveillance is there as per the guidelines, and that has to be continued after even the normal HCG level is achieved, and sometimes the surveillance is lifelong. And for the survivors, there are a lot of things are there for the next childbirth and next planning. All these things are there. Thank you, ladies and gentlemen, for very patience holding your nerves, and thank you very much. And this isolation during the corona is an opportunity for all of us to explore the academics, and I will be coming with other topics in next class very shortly. Till then, bye bye, and have a confinement of yourself. Be safe to yourself and safe to your family and the community. Thank you. Bye bye, ladies and gentlemen. Thank you.